fall day.
Yeah, we can see out the window behind you. It looks nice.
Yeah.
So why don't we get started? And I know there's still people joining us. So to all those in attendance and those logging in, welcome to a special Cancer Center Grand Rounds. We're very privileged to honor the legacy of Dr. John Murren and have a very special guest as our 2020 memorial lecturer. And I want to introduce Roy Herbst, who, as everyone knows, is our Chief of Medical Oncology and Associate Cancer Center Director for Translational Science and leader of our lung spore, among other things, to speak about the lectureship and introduce our speaker. So Roy, thank you.
Thanks, Charlie, and thanks everyone for joining. This is a very special lecture because it honors our colleague and friend, John Murren. If we can go to the next slide, please. Emily. So many people who are on the line knew John. I see John's sister, Mary Kay, is on, and his wife, Nancy, and perhaps others of the family. One of the special things about this lecture is we usually can get together and talk in person. Hopefully that will happen again next year. But no, John was a very special person. And, as many of us know, he passed away in 2005 of melanoma at the young age of 47. He was an associate professor of medicine at Yale. And he was the director of the outpatient center, director of the lung cancer clinic. I would not probably be here at Yale if not for John, and co-leader of the experimental therapeutics program at the Yale Cancer Center. He was survived by his wife, Nancy, his son, John, his mother, Jean, and I know that Nancy is here and maybe Jean. Many knew John even better than me. I knew him from the clinical trials and from meetings. He was really the consummate medical oncologist academically. He was just the most caring physician, an active laboratory, working to develop new treatments, very insightful. And really the top program that we have today is in large part due to John and his efforts. He had some efforts through his family in Las Vegas, and Yale had some interactions there for a while. But really he just was someone that we all knew and loved. And one of the reasons we've invited today's speaker is not only is she an amazing researcher and clinician in lung cancer, but she knew him as well through the ECOG, where John was a major person. So really very glad to have this lecture. I gave this lecture 11 years ago. So it's really a pleasure to introduce today's speaker. If we can go to the next slide, please. So in thinking about this, this is the second time we've scheduled this with Heather. And we just decided we would do this virtually because we were so lucky that Heather agreed to come and speak with us. Dr. Heather Wakelee is a professor of medicine and the interim chief in the Division of Oncology at Stanford University and the president-elect of the International Association for the Study of Lung Cancer, the ISLAC. She received her medical degree from Johns Hopkins University and completed all of her postgraduate training at Stanford University before joining the faculty in 2003. Heather specializes in the treatment of lung cancer, thymoma, and mesothelioma, and has developed research programs related to lung cancer and thymoma across multiple areas, including clinical trials, translational work, and population sciences. She is a principal investigator on numerous clinical trials that have changed the pattern of care, and is a faculty director of the Stanford Cancer Clinical Trials Office and lead investigator for ECOG Akron Clinical Trials Group at Stanford. She also is active in many organizations, but actually I've shared many patients with her. She's also the most compassionate physician and the person that I would call whenever I have a difficult case, especially in the EGFR field. In fact, I did that last night. So if you go to the next slide, we normally at this point I would be handing Heather her plaque, but due to the amazing efficiency of Yale Cancer Center, Heather has it. Show us. So it already arrived.
Can you see it? So here we go.
Yeah. And then last night we actually had a little get together, some of us on Zoom, and you can see Pam Kuntz there, who we recruited out of Heather's group, and we did a little Zoom happy hour and without drinks, but just talked about John, talked about lung cancer. So Heather, it's wonderful to have you here today. Thank you to the Murren family for your support, and again, we miss John so much. But we're looking forward in his memory to a wonderful lecture from Heather Wakelee, 15 Years of Advances in EGFR Mutant Lung Cancer. Heather, welcome to Yale.
Thank you. Thanks, Roy, for that very kind introduction and for inviting me to be here today. I really wish I could be there in person to get to visit with all of you, tour the campus, which I haven't seen in a few years. I know there's been a lot of development, and I really would have valued getting to meet with the Marin family. As Roy mentioned, I did know John. I was pretty early in my career, but he was very welcoming when I showed up at the ECOG Akron meetings. I remember having several conversations with him. And I very vividly remember when I heard of his death and how devastating that was for me, for our whole lung cancer community. And so when Roy invited me to give this talk, and I was thinking about what could I cover, I thought about the fact that we lost John 15 years ago, and thought about how much the world of lung cancer therapy has changed during that time, and wanted to use the story with EGFR lung cancer as a real example of one of the most dramatic changes that have happened during that time period. But I also wanted to weave in a different story, and that was about patient communication. And so I'm also going to be talking about that and framing it a little bit around another physician who unfortunately we lost to cancer and who has a connection to Yale as well, and that's Paul Kalanithi. And his When Breath Becomes Air book, I was his physician, and in that book he talked a lot about his philosophy about living as well, first of all, as being a care provider, physician for patients facing cancer and other serious issues, but then as a patient and how he thought about living as a patient. And he really captured a lot of the ways I think about things and as we talked together. And so I wanted to share that as well. So I'm going to try to do over the next hour. I'm going to go ahead and share my screen here and give you the talk. Okay, and view slideshow. Okay, so hopefully you're seeing this now. So I titled this 15 Years of Advances in EGFR Mutant Non-Small Cell Lung Cancer, and then with the focus on patient communication. These are my disclosures. And then as I thought about learning objectives, it was to really talk about how that EGFR field has evolved over time, specifically the EGFR TKIs, and then a couple of things we're looking at adding to EGFR therapy, and then talk about communication. So when we think about advances in the treatment, EGFR TKIs alone, VEGF combinations, EGFR combinations, chemotherapy, immune therapy, and then the communication. So back in 2000, as I was just starting my time as an oncologist, this was the state of the art. And what this is showing is survival curves from a trial where patients were treated with only things we knew to use, which was just chemotherapy combinations. And you can see that we hadn't made a whole lot of progress. We were helping people, but not for nearly long enough, and without really being able to distinguish what was the best treatment for any given patient, because all of these different chemotherapy combinations looked about the same. But many people realized that there were things about lung cancer that were different than some normal tissue. And one of them was a high expression of this EGFR, or epidermal growth factor receptor protein. And what this cartoon is showing is that the epidermal growth factor receptor is a protein, it's a receptor, it's on the cell surface, and it's sitting out there with EGF binding to it, and then it sets off a whole bunch of signaling, which does a lot within the cell regarding growth of cell, survival of cell. And so it was thought that EGFR was likely pretty important in lung cancer. And you'll notice one of these reviews was written by Roy. And so people developed different ways to target EGFR, the most common being these tyrosine kinase inhibitors. So this is the tyrosine kinase receptor, ligand binds, and then you get signaling down here in the tyrosine kinase domain. So these medications that are pill drugs, oral, can block that tyrosine kinase activity. Then the first of these developed was gefitinib, and I'm going to talk about each of these drugs a little bit. But there are other strategies to hit tyrosine kinases. One is to block where the ligand would bind, and we'll talk about a couple of drugs that do that. And then another is to just take all the ligand, what would be binding and turning things on, and remove it. And that's a different approach that's used as well. So just wanted to give this cartoon to set people in mind about thinking how the drugs work. So the first drug, gefitinib, and you see Dr. Herbst, of course, was involved in that, was given to patients with lung cancer. And it was noted that some people, maybe 10%, had these dramatic responses, which was really exciting, but we didn't know how to select them. And this led to a larger trial with a similar drug called erlotinib, where patients received this drug in the second or third line, or they got placebo. And when you looked at it, response rates were about 10%. Survival wasn't great, but it was better than placebo. And so this was really exciting at the time to see that 2-month improvement. But what was really interesting is people noticed that it wasn't just random who was responding. It tended to be women, it tended to be people with the adenocarcinoma type of lung cancer, and especially people who had lung cancer who had never smoked. And also noticed that a lot of them were of Asian ethnicity. And so this led to the study known as the IPASS trial, which was conducted in Asia. It was done in people who had a very limited smoking history, but who had developed adenocarcinoma lung cancer. And this ended up being mostly women. And they were randomized to either get the EGFR pill drug gefitinib or chemotherapy. And I showed you that before, the chemotherapy drugs are all about the same when we look at them. And what was interesting is when the results came out, it was very confusing at first, because when you look at the progression-free survival, which is the time either that someone's no longer alive or that their tumor has started to grow, so the progression time, these curves kind of crossed, and the chemo was looking better until about 5 months, 6 months, and then the gefitinib. So it wasn't a very clear story. And when we looked at overall survival, there wasn't any difference. So it wasn't clear that this gefitinib drug was really doing anything special. But while that study was being conducted, so starting in around 2005, and again, this is the 15-year story, scientists at several institutions realized that these patients who had these dramatic responses, they did testing on their tumors, and they found that the tumors had a change in the EGFR protein that was really related to a mutation that had happened in the cancer cells. So in the cancer cells, EGFR became mutated and became turned on all the time, constitutively active. And that looked like it was what was driving the cancer, because none of those mutations were found in the tumors of patients who didn't respond, but they were found in almost every tumor of a patient who did respond. And so that led to sort of the aha moment that changed how we think about treating lung cancer. Because when they went back and tested the tumor samples from the patients who had been on the IPASS trial, they were able to come up with a very different story. That patients whose tumors had the EGFR mutation did much better with gefitinib, much higher responses. It worked for much longer than chemo. But for people whose tumors did not have that, even though they otherwise looked the same, it didn't work at all. And so that was the first moment for us in lung cancer to realize we needed to look. We couldn't just determine based on what the patient looked like or what their tumor looked like under the microscope. We needed to test. And if we could find the EGFR mutation, then we could actually treat the tumors differently and have better outcomes. And I'm focusing on EGFR today, but we now know to think about and look for mutations in 7 different genes. In lung cancer, it's actually closer to 10 now, but we have 7 where we have FDA-approved medications, and we can think about using those instead of chemotherapy up front. So this was a complete revolution in how we think about treating lung cancer. And this study really was what got us there. So I'm focusing on that quite a bit. In this particular trial, by selecting the way they did, about 60% of patients had EGFR mutations, and those numbers vary around the world and based on who the person is who's gotten the cancer, but it's not specific just to women in Asia. I have a lot of my patients here in California wouldn't fit that demographic, but yet their tumor has an EGFR mutation, and they respond as if anybody else who has that EGFR mutation in their tumor. We've now had multiple other studies that have looked at giving EGFR TKI drugs versus chemo in patients whose tumor have an EGFR mutation. And you can see that in all of them, the progression-free survival time was much, much better with the EGFR drug, but it wasn't forever. And that's because we get resistance. And this is a slide that goes back a little bit now, but what was figured out was that in order for a cancer to have an EGFR mutation, that we don't know why that happens. We're still trying to figure that out. But when the tumor has that EGFR mutation, the tumors respond really well to an EGFR tyrosine kinase drug. But over time, resistance develops because new mutations happen. And in the setting of EGFR, with these initially developed EGFR drugs, most of the time when those stopped working, it was because another EGFR mutation developed, and that was called T790M. So we spent many years trying to figure out a way to treat T790M. I have a lot of old studies that didn't go anywhere, and many medications we worked with, but then came along this drug Osimertinib, which is the third generation EGFR drug, and it works when T790M is there. So what these are showing is you've got the line. If you've got lines above it, that means that the tumors grew, but everything below the line means that the tumor shrunk. So you can see that for most of these, the tumors were shrinking when a patient received Osimertinib after they'd already had either the gefitinib or erlotinib. So if they'd been on a first generation drug and it stopped working, and then they took this third generation drug Osimertinib, most of the time the tumor shrunk. And that's because we were actually getting that T790M target. So to prove that, there was a trial for patients who had been found to have EGFR mutation in their tumor at the beginning. They started on a first or second generation EGFR medicine. And then when it stopped working, they were on a trial randomized to either get Osimertinib or to get chemotherapy. And what this showed us was that that progression-free survival was clearly better with the Osimertinib versus the chemotherapy. So it became standard that you would test when someone was diagnosed. If their tumor had the EGFR mutation, you would start them on erlotinib or gefitinib. And when that stopped working, if the T790M mutation was there, then Osimertinib was a better choice than going with the chemotherapy. But finding the T790M wasn't perfect. So there were several different ways to do that. You could either look with tissue or in the blood with plasma testing. And we also did some urine testing, but we don't do that so much anymore. And what this is showing is that most of the time you could find that T790M in the tissue and in the plasma, but there were sometimes you could only find it in the tissue. And that's because it wasn't being shed out into the DNA wasn't going out into the blood. Or you only found it in the plasma, and that's perhaps because when you did the biopsy, you didn't get enough of the cancer cells, or there's some heterogeneity, meaning that not all of the cancer cells change at the same time in the same way. So you can have areas that are resistant because of this mutation and other areas that are not. And so I'm not going to go into that today in 1 hour. You can't cover everything, but I wanted to at least mention this because it is important to know that when you have a cancer, it's evolving over time, and the way that we find out more about it is we need to sample it. And historically that was always with tissue, but now we can look at it with these plasma tests as well. But that's all I'm going to say on that topic. Okay, so we know to test. We know to give a first generation drug. We know T790M develops, so then you use this third generation drug. But of course people wondered, why don't we just give this third generation drug first, and then T790M won't develop? So that was this Flora trial, where patients who were newly diagnosed and found to have EGFR mutation either got Osimertinib or got a first generation drug. And that study clearly showed that Osimertinib was better for that progression-free survival, meaning that it took longer before the cancer started to grow. However, it also led to overall survival improvement. And that's because even though theoretically, if you started on a first generation drug and then developed resistance, you could go on Osimertinib if it was T790M. There are other things that cause resistance. And so delaying that time to resistance with the Osimertinib, even when it's not resistance due to T790M, overall survival was better. And so this has become the standard approach in the US. But unfortunately, as you see, these curves eventually do come down. We're not curing people. And therefore, we still need to think about better things to do. So when we kind of summarize this first part about EGFR, we need to test to find the EGFR mutation. And usually that's done with the tissue testing, but we can also sometimes find it in the plasma with blood testing. If you find an EGFR mutation, we start on an EGFR TKI. Osimertinib is what we tend to use in the US, but there are multiple other EGFR tyrosine kinase drugs which are approved in the US and globally, and so those are still used as well. And as I mentioned, we're still thwarted by resistance. So with osimertinib, it's not such a simple story like it is with the first generation drugs where we get one resistance pathway, which is that T790M resistance as the predominant one. When there's osimertinib resistance, there are a lot of different things that can happen. You can get other EGFR mutations, and T797S is the most common of those, but there are a lot of other pathways that can go be abnormal as well. And so it's quite complex, and there's a lot of research being done there. And this is just a graphic showing some of those resistances. So I talked about the T790M here with first and second generation, but there's also overexpression of MET and mutations in other genes, and also a transformation to small cell. So it's not always straightforward. And then with osimertinib, there can be changes in what the EGFR kind of percentage of expression of the protein is. It's never gone, the EGFR mutation's never gone, but the way it's expressed is different. But you also can have MET overexpression is fairly common, or changes in BRAF. We just were talking about a case this morning at Stanford with another patient who had been on osimertinib and then developed a BRAF mutation, and many, many others. So again, it's quite complex as we talk about bypass tracks and EGFR target alterations. So then what do? You got to think outside of that. Here's the target, hit the target. We've got to be broader. Here's a target, hit the target is great, and it's helped people tremendously for an extended period of time, but we want to extend it even further. So what can we do? We try something else. So we have antiangiogenesis is one of those, and that's getting at the fact that in order for some tumor cells to grow into a tumor, they need to have blood vessels to feed them. And so this is angiogenesis. And that's where we get drugs such as Bevacizumab and many others. And there have been a ton of trials noticing that in the EGFR setting, VEGF is also very important. And so a lot of trials looking at in a patient with EGFR mutant lung cancer, you can give the EGFR medicine, but you can also give it with anti-VEGF therapy, and that theoretically should make a big difference. So one of the first trials was the beta trial led by Dr. Herbst. And in this study, it wasn't selected for patients with EGFR mutation because this was done before we knew about the EGFR mutations, and we were just giving erlotinib to people after they'd already had chemo. But this showed that even without that, giving the bevacizumab added to the erlotinib improved the progression-free survival. And in the small group of patients who went back and found that they actually had an EGFR mutation, there was a signal that there might even be an overall survival benefit by adding the bevacizumab to erlotinib. So there have been multiple other trials. This was a phase 2 study done in Japan, where patients with EGFR mutant lung cancer received either erlotinib, the pill every day, or erlotinib plus the bevacizumab, and bevacizumab's an antibody. It's given IV every 3 weeks. And this study showed a marked improvement in progression-free survival. This actually led to approval of this combination in Europe, but not in the US. With longer-term follow-up, though, it turned out that despite that huge progression-free survival benefit, there was no overall survival benefit. And so it's a little bit unclear what we're doing with this combination. Perhaps it's helpful to prolong the time that the erlotinib stops working. It turns out that if you're on erlotinib and bevacizumab, the most common resistance pathway still is that T790M. So if you're on this combination and then resistance develops, you can go on to get the osimertinib, but there are other things that happen besides T790M, and then no overall survival benefit. So a little bit unclear. There was a randomized phase 3 trial also done in Japan, which had very similar results, a nice progression-free survival benefit, but no overall survival benefit. And this is news. This just was presented at our ASCO meeting in June of 2020. So we were waiting on this, and now we kind of are seeing this similar story emerging, but it's more complex than that. In the US, we also have the sorlatinib and ramucirumab. So I showed at the very beginning the different ways to target these tyrosine kinases. So the first were the tyrosine kinase inhibitors, which work in the cell at the tyrosine kinase domain. But then I also showed two different strategies for antibodies. One, the bevacizumab type, where it's binding to the ligand, so sucking all the ligand away. The other binds to the receptor and sort of blocks the way the receptor works. So ramucirumab is blocking VEGF receptor. So you've got erlotinib, the tyrosine kinase inhibitor, blocking the tyrosine kinase activity, and then VEGF, not EGF, but VEGF related, is also being blocked. So you get a blockage that way. And you see this nice progression-free survival benefit, but we haven't seen the overall survival data yet. This combination is approved as an option in the United States, but I think that we're waiting to see what that overall survival data is going to look like. Now, I've talked about erlotinib here, but you're thinking, the beginning you were telling me that osimertinib is preferred over these. So where's the osimertinib bevacizumab data? Well, here's some of it. So this was data that Helena Yu and the Memorial Sloan Kettering group put together. This is not randomized. This is just patients getting osimertinib and bevacizumab. And the toxicity was manageable. And the response rate was very high at 80%. And the median time to when the drugs combination stopped working was about 19 months. So that's interesting. It's not overwhelming, but interesting. However, there was this very confusing presentation that we saw just last month, or 2 months ago now in September, at the ESMO meeting, the 2020, which was a randomized phase 2 of osimertinib plus or minus bevacizumab, again done in Japan. And when you look at this, the blue line is actually the osimertinib alone. So in this particular trial, the combination of osimertinib and bevacizumab looked worse for progression-free survival than just the osimertinib alone. So that's a little bit confusing. The osimertinib alone progression-free survival was lower than, well, I should say, this was done second line. So this was for patients who had had erlotinib or gefitinib already, had developed T790M, and then went on osimertinib. So it's different than the first line data. But in this trial with osimertinib plus or minus bevacizumab in the second line, the osimertinib alone outperformed the combination. Now, this is a randomized phase 2 trial, so we have to be careful. Sometimes randomized phase 2 studies don't give us the truth. This study did show that the response to the combination was higher than the single drug, but just not that progression-free survival benefit. So we're kind of confused by this result. We are moving forward with the next line of exploring this, though. So this is a randomized phase study, randomized phase 3 study in the ECOG-ACRIM network, led by Helena Yu and Blas Halmos. And this is for patients who have just been diagnosed. So the one I just showed you was second line. This is first line, patients just diagnosed with lung cancer that has an EGFR mutation, and they're going to get osimertinib plus or minus bevacizumab. And the study just opened to enrollment, so we have no data yet, but we're excited to participate. Though, again, as we talk about this option with patients, it'll be important to talk about the data that we've already seen with the other combinations of EGFR TKI plus or minus a VEGF drug. So we're still kind of trying to understand this. And there's also an osimertinib ramucirumab trial ongoing. Okay, so leaving that. And now on to, so hopefully you're following, EGFR TKI alone, EGFR TKI plus or minus these antiangiogenesis drugs. And now we're looking at EGFR combinations. And this is where we're looking at an EGFR TKI pill plus an antibody drug that's also hitting that EGFR protein. And if you think again about that first slide I showed you or early on, where you've got the different strategies, if you've got a receptor, tyrosine kinase inhibitor, or tyrosine kinase, if you block at the tyrosine kinase domain, but you also block at that receptor point, you're hitting the same protein in two ways. And so that's the theory behind why this would work. And long ago, before we had osimertinib, so going back in time, we had a combination of an EGFR pill drug, afatinib, plus an EGFR antibody, cetuximab. And this combination was the first combination and the first thing we ever saw that worked in the setting of having been on a first generation drug, developing T790M. So before we had anything else, this combination worked. And so this was the original publication. And again, this is a waterfall plot. So you see a few patients had their tumors grow, but a lot of patients had their tumors shrink. And so this was an option that we had for a while, but now we don't use it too much because of osimertinib, but we're coming back to study it. And so there are combinations now of osimertinib plus a different EGFR antibody, necitumumab. So we're part of this California Cancer Consortium study. Jonathan Rees has talked about some of the preliminary data at ASCO last year and more ongoing. So encouraging information here. And this is being looked at for patients who have already been on osimertinib and it stopped working or early on. There are also combinations with afatinib and necitumumab, and we're part of that consortium, which is with Vanderbilt. So a lot of work still looking at this, but some toxicity issues. So we'll see how that pans out. There are also newer drugs being developed that build on this. So one is this amivantamab drug, which is a combination of EGFR antibody. It's also hitting MET. So if you were paying close attention, you'll notice I mentioned MET as a potential resistance mechanism. And so there's data to support looking at MET. There have been a lot of trials looking at specific MET inhibitors in the EGFR world. Again, I only have an hour, so I couldn't go into all of that. They haven't really gone too far yet. We haven't changed our treatment, but we haven't forgotten about MET. So we're looking at EGFR MET antibody here, the amivantamab, in combination with a different third generation drug, lazertinib. And so this was data that was just presented at ESMO, which was encouraging, showing that for patients who had already had osimertinib, in this preliminary data, about a third of those patients did respond to this new combination. So we'll see how that pans out, how long it works, what the toxicity is. So there is movement and excitement about new combinations. There are also newer EGF pathway, or this is the a new drug, U3-1402, or pertuzumab deruxtecan. And this drug is looking at HER3. And you're confused now because you're thinking, you're talking about EGFR. Why are you talking about HER3? Well, EGFR is also called HER1. So HER1 and HER2 and HER3 are all in the same family, and they do interact with each other. So this antibody drug conjugate that's focused on HER3, there's hope and some data now showing that it could be active in the setting where there's EGFR driven lung cancer. So this is, again, some very preliminary data where they were looking at patients who had EGFR mutant lung cancer, had previously received osimertinib, or had developed resistance to erlotinib or gefitinib and didn't have T790M. And again, on this waterfall plot, you can see that there have definitely been some responses. And the details here are all about, well, what was the resistance mechanism? What was the underlying EGFR mutation? What resistance was seen? And so there's a lot to parse through here, which I won't go into, but encouraging new data. Okay, so now we've talked about EGFR TKIs alone, VEGF, novel EGF combinations, and now I'm going to switch to chemo and talk about EGFR TKIs and chemo. So again, bear with me here. This is it's a lot to go through, but there's been so much we've been exploring and trying to understand how do we do a better job of treating patients with EGFR mutant lung cancer. So what about combining chemotherapy and EGFR TKIs? Well, when we first learned about the EGFR TKIs, there were big trials combining them with chemo. This is the Tribute and Talent studies. And again, Dr. Herbst played a big role in these. And these studies were completely, absolutely negative. And this was done before we knew about EGFR mutant lung cancer. We were treating everybody the same, but totally negative studies. And so this led us to not really think about this approach for a while. There was some work looking at this intercalation idea where you would use the EGFR TKI, stop it, get the cells signaling again, give the chemo, restart the EGFR TKI. And this actually was encouraging. It showed an overall survival benefit. But people don't really want to be on chemo if they can just take a pill. And so this was not widely adopted. People looked at whether when you were on a first generation EGFR drug and it stopped working and you were going to go to chemo, this was before osimertinib, whether you could continue the EGFR drug or if you should stop it. And this was the IMPRESS trial, and that didn't work either. There was no benefit. And if anything, survival favored stopping the gefitinib and just going with chemo. So we had these big randomized trials, combinations negative. We had this trial negative if you combine the EGFR TKI and the chemo together. So not a lot of enthusiasm, but a lot of questions still, because the idea of stopping an EGFR TKI for a tumor that was dependent on it doesn't make a lot of sense to many people. And so lots of debate on this. And then we had 2 trials that came out, which changed again the way that we think about this. So this was a trial done in Japan, chemotherapy with an EGFR TKI. So this was in patients who were newly diagnosed EGFR mutant lung cancer, and they either got the EGFR drug gefitinib or they got gefitinib plus chemo. If they got gefitinib plus chemo, they stayed on maintenance, and at the time it stopped working, they went on to other therapy. If they got gefitinib alone, when it stopped working, they stopped it and went to chemo. So it's sort of you get everything together, the chemo plus the EGFR drug, or you get it sequentially, EGFR and then chemo. Again, no osimertinib here. This was designed before there was osimertinib. And when you think about, this was the first progression-free survival. So this was for patients who had chemo plus gefitinib versus gefitinib. And the chemo plus gefitinib group stayed on the drug longer. They were still on it for like 21 months. The group only getting gefitinib, it only worked about 11 months. You're like, okay, right. But what you really want to know is everything together, concurrent versus the sequential. And when you looked at everybody together, concurrent versus sequential, the sequential group caught up when they went from their gefitinib to chemo. It all ended up being the same. And you think, okay, negative study. Except overall survival actually showed a benefit to having gotten everything at the beginning. So this has us a little bit confused. Why would getting everything at the beginning be better than the A and then B if the progression-free survivals were the same? So we're still trying to figure this out. But there was another study that was done in India, similar design, that also showed that there was a progression-free and an overall survival benefit. This is a little bit different because not everybody who started on gefitinib got the chemo afterwards, but it kind of supports that. And so there are ongoing trials now looking at this question and including a study with osimertinib. So we'll see how this pans out. And now I'm going to shift gears again and go to immune therapy, because that's the other big revolution that's happened in the last 15 years, but it hasn't changed EGFR lung cancer much. When we look at the first trials that got immune therapy, so these are the PD-1, PD-L1 checkpoint inhibitors approved in lung cancer, they were given second line to people who had already had chemo, some of whom were had EGFR lung cancer and had already had EGFR lung treatments as well. They were the only subgroup that didn't do well with the checkpoint inhibitor. So in these older trials, and I'm looking here at this box, of docetaxel chemo versus checkpoint inhibitors, those trials showed overall survival benefits to everybody with the checkpoint inhibitors, except patients who had EGFR mutations. So when we got to the bigger trials in first line, patients with EGFR mutations weren't included on those trials. So we have very little data. This one study that came out of the Atlantic trial, which was a phase 2 study, showed that if you had EGFR mutant lung cancer and your PD-L1 level was high, sometimes the checkpoint inhibitors worked about 12% of the time. But if you had low and EGFR mutation, it never worked. People have done TKI plus immune therapy combinations, and they've been totally negative. A lot of toxicity, no clear benefit. So we don't get too enthusiastic about checkpoint inhibitors in EGFR, but we think about it. There was one trial, this Empower 150 study, that was chemo plus bevacizumab plus immune therapy that allowed for patients with EGFR mutations. And that study did show a potential survival benefit in the subset, but we have to be really careful because this was a small subset of a bigger study. It wasn't really powered to answer the specific question. And so there are ongoing trials now looking at this. So we still have questions around what do we do with immune therapy in the setting of EGFR lung cancer. So to put all that together, EGFR TKIs improve response rate and progression-free survival compared to first-line chemotherapy. But you have to test. You have to know the EGFR mutation is there. Osimertinib is our preferred first-line treatment from the Flora trial. VEGF inhibition improves response and progression-free survival when added to EGFR TKIs, but we don't know if it improves overall survival. Chemotherapy may improve overall survival in combination with EGFR TKIs, but we're still trying to answer that definitively. And immune therapy activity is very, very limited, and there's a lot we need to explore there. And we're still dealing with the fact that resistance develops. So we've made tremendous progress, but we still have a long way to go. And that's where communication is so important, because some patients do remarkably well. I was meeting with one of my patients yesterday I've been caring for 8 years with metastatic EGFR mutant lung cancer. And you know, we're having to think about her next line of treatment, but she's still on erlotinib and it's been 8 years. Some patients do remarkably poorly. Another patient I saw, I think it was last Thursday, he's never had a good response to anything, even though he has a clear EGFR mutation in his lung cancer. And so why are they different? I can't tell just based on the EGFR mutations that they have. There are other factors that we're trying to understand, but it's important then that when we talk about how someone's going to do, we're never too confident in that because we really don't know. So we can often predict outcomes, but we can't always. And we have to strive to keep the trust of the patient and their family to help them really live given this uncertainty. And so I'd mentioned, I'm going to weave this in a little bit. So this was When Breath Becomes Air, written by Paul Kalanithi, a Yale medical student, who then went on to do his neurosurgical training at Stanford. And he unfortunately died of EGFR mutant lung cancer. But while he was living with his disease, he wrote this amazing book. And one of the quotes that I really love from this is that the reason that doctors don't give patients specific prognosis is not merely because they cannot. What patients seek is not scientific knowledge that doctors hide, but existential authenticity each person must find on his or her own. Getting too deeply into statistics is like trying to quench a thirst with salty water. The angst of facing mortality has no remedy and probability. And so that really captures the essence, I think, of what we tried to do in this communication setting, but written obviously far more eloquently than I would ever have been able to do. And obviously we miss Paul very much. So when we talk about communication tips, these are a few of the things that I like to think about. One of them is about the numbers, just as Paul said, but numbers get remembered. If you have an hour-long conversation with the patient and you mention a number, when they leave the conversation, that's what they will remember. So you have to be very careful how you use them, and be very careful how prognosis is discussed. Avoid quoting medians, because if you quote a median, again, that's the only thing someone remembers, not everything we know about what a median means. So always give a range. And I talk about the worst possible outcomes, but I also talk about the best. But whenever I talk about the best, I always make sure I can think of a specific person who was there, because otherwise you're just making a number up out of the air. And the prognosis for any individual, of course, evolves over time. So help the patient to understand that and their family. And then try to guide the patient in making the life decisions they need to make based on probabilities of how much time they have, knowing that there's that uncertainty. Encouraging patients to think about the things they need to do and also about what they want to do. It's really a terrible thing if someone assumes that they have many years left when they don't, and therefore they don't do the things they would have done if they had known that they didn't have a lot of time. But it's also terrible to take away hope from someone, because there always is that uncertainty. So you try to guide, but leave uncertainty. Ongoing dialogue is obviously critical. I bring up the concept of risk and benefit in regard to therapy fairly early, and I frequently talk about that when I'm reviewing things, because at some point we are going to get to that point where the risk of ongoing therapy is going to outweigh the potential benefit. And if you bring that up for the first time, then it's a much more difficult conversation. It's also really critical as you engage the patient, who's the key person in all of this. You've got to make sure the family also knows what's going on and is aware of the information that you're talking about, because the family is going to live with the memory of the patient forever. And it's really important that they're a part of those decisions as much as possible, not to guide the patient because it needs to be the patient's choices, but to understand how the patient was making those choices. And to be a part of that, I think that really helps with the peace for the family as they continue living, having lost an important loved one. When having a frank conversation, pay careful attention to how you're being heard. Harder now in the world of Zoom, much easier when you're in a room with someone and you can watch the body language and the faces and make sure that everyone's engaged and understanding so that you can back up and rephrase as necessary to get everyone together. Really important to check back in with the family and the patient if you're making a decision, to have everybody understand why that decision was made, why we're choosing a particular therapy over another, because it's not always going to work. And it's important that everybody knows how we ended up making that decision together. If you hear a really strong objection to a particular treatment, it's always good to ask why. There are a lot of stories that people have based on their own experiences, a family member's experiences, someone they heard about bad experience, to understand why what the particular patient's facing is either similar or different. That can help a lot too. If at all possible, never answer your phone or pager when you're in with the patient. 100% attention really matters. No matter how crazy or busy things are in clinic, and for those of us who are clinicians, you know, you walk out of the exam room and you got 5 people talking with you about different things, and you're trying to process all of that. But when you go back in the exam room, you just have to be there 100% calm, you're listening. And that really makes a big difference also. Because really the key is being sure that the patient and the family know that you care about your patient as a person and that you are guiding them to make the best decisions that can help them live as long as possible with good quality of life. And I'm going to end then with a quote from Jill Feldman, who's an amazing patient advocate in the EGFR world. And she does a lot with the ISLC. She is a frequent speaker at our conferences, including our North America conference. And we were just there together a few weeks ago. And she talked about treating the whole patient on an intellectual, physical, and emotional level. We need to know that the doctor caring for us as a patient cares about us. What we patients value can't be quantified in a curve. Hazard ratios and clinical trial numbers don't translate to real life or capture the unquantifiable meaning of a person's life. So I thought she really, really summed it up well with that. Okay, so overall summary. Over the last 15 years, we know that EGFR TKIs alone are the standard of care in a patient with EGFR mutant lung cancer, but you have to find the mutation. VEGF combinations are encouraging, but so far we haven't seen that translate into overall survival benefit. EGFR combinations look really promising, but not standard yet. Chemotherapy combinations maybe will move into first line, seem to improve overall survival, but we haven't really bought that concept yet. Immune therapy, that's a promise for so many patients living with lung cancer and other cancers now, but in the world of EGFR therapy, there's a lot we don't understand yet. And that brings us to the fact that for all of these advances and wonderful things that we do, we still aren't curing people. We still have a lot that we need to do. I have intentionally not gone into what do we do in early stage lung cancer therapy today, because there have been some tremendous advances there with the Flora Trial and other ways of looking at bringing in EGFR therapy earlier to those patients who can theoretically be cured. Today, I wanted to really focus on metastatic disease and the fact that with all that we can do, it's still about communication and really to help our patients make the right choices for themselves and to live despite facing the uncertainties of cancer. So thank you. Oh, you're on mute, Roy.
Thanks, Heather. That was wonderful and really great to see the progress made in 15 years. A lot of it, stimulated by the work of John and others. We're open for questions now. I guess we do questions in the chat room. I see Charles here. Maybe we'll start with a few while they come in. For the EGFR mutated lung cancer, of course, you see a lot of it, especially where you live, because it's more prominent in Asians. Do we know yet why? Has anyone looked at the genetics of that to understand, are there certain sequences or genetics that can explain that?
So that's a great question. So there are multiple efforts ongoing to try to answer that question. So my last international trip before travel ended was last January. I was in Taipei, Taiwan, James Yang had invited me to the National Taiwan University, and there's amazing work being done there and in multiple other Asian countries, trying to look at the nuances, the subtleties. They've done a lot of screening as well that involves screening in non-smokers, trying to figure out, you know, what's happening. And they've very clearly shown a significant increase in adenocarcinoma of the lung in non-smokers, and it's both in men and in women. I'm actually working with the group that's from UC Davis, University of California, Davis, University of California, San Francisco, and then Stanford. We have an R01 that's funding a case control study that we're doing, looking at Asian never smoking women who've developed lung cancer, almost all of whom have EGFR mutations, and then doing a match control of very similar people who don't have lung cancer and trying to see if what we are able to find there. And that of course involves sample collections as well. And there are a lot of similar ongoing efforts, but we don't know. And for me here in Northern California, though, a lot of my patients with EGFR mutant lung cancer are never smoking Asian women. I also have a whole lot of people of multiple different ethnicities, men and women, different age ranges, who also have EGFR mutant lung cancer. So it's not just that group, but there's got to be something, because it does seem to be increasing, and we're still baffled as to what that is.
Great, thanks. For the next question, we have a special guest. 15 years ago, a young Scott Gettinger came to Yale to work with John. Sadly, they only worked together for about a year, but Scott turned out okay. John must have done okay with you. So Scott, I'm going to move over so I put my mask on. Scott's going to ask a live question. He's our DART leader in lung cancer.
Hi, Heather.
Hey, Scott. Nice to see you.
See you. Great talk. I don't think you got into it too much, but I'm just curious, for your patients who progress at multiple sites while getting Osimertinib, do you continue, who are not trial candidates, do you continue the Osimertinib with the chemotherapy? Do you stop it along the lines of the IMPRESS trial, where we didn't see a benefit from at least first generation TKIs? How do you handle that situation?
That's a great question. So obviously it's different for different folks. So first, to answer the first part of the question you didn't actually ask, which is if someone's progressing in a single or a couple areas, we will continue Osimertinib and do radiation or other local ablative therapy whenever possible, and try to extend the time that they're on that treatment. If we get to a point where they are definitely needing to switch to a different systemic therapy, looking for trials first and foremost. But if we can't, and they're going to switch to chemo not on a trial, it'll depend on the patient. If they have significant amount of brain disease, I will continue the Osimertinib and start them on the chemotherapy, continuing Osimertinib. For some of the other patients, I will stop it. And part of my rationale behind that is I watch them closely. I do believe that flare can happen, but it's pretty rare. So if a patient suddenly gets drastically worse and we stop the EGFR drug, they're back on it, they stay on it. I've had that happen more in people with bone metastases. And interestingly, I think if you read When Breath Becomes Air, Paul was one of the people I continued on, and he never got Osimertinib, but because his disease was before that. But I continued him on because he was someone who, as soon as we stopped, he had bone pain. So he was definitely someone who flared, so he never stopped. But for other patients, I will stop. And part of the rationale is that by stopping the EGFR TKI in the patients where you can, and going with chemotherapy, the resistance that develops at that point after they've been on chemo for a while tends to be much more responsive to restarting an EGFR TKI in a context of a study or some combination. So that's why I'll think about it. But a lot of my longer term patients right now, we don't stop because they've had things where they've had bone mets or other problems. So
Thank you.
Yeah.
Great, thanks, Scott. We have a few questions in the chat room. It's from Sarah Goldberg.
Hi, Sarah.
Who was with us last night.
Yeah.
You see any promising avenues for using immunotherapy in EGFR mutant lung cancer patients beyond PD-1 agents?
Ooh, great question, Sarah. So I'll, again, answer the first part of that. So with the checkpoint inhibitors, I've had a couple of patients who've done very well with them. They were patients tending to have L858R, not deletion 19, and that's something that in Taiwan they've been looking at a lot also. Tended to have high PD-L1, and so a couple of folks have done well. And we are participating in a study looking at chemo with carboplatin, pemetrexed, and bevacizumab, plus or minus atezo. So this is a multi-site study. So I think there might be room there, but it's not something I'm doing as often off trial. As far as other immune modulators, yes, but I'm not a good enough immunologist to tell you exactly what that's going to be. I think that it's something that a lot of us are watching really closely to try to understand what is it. You know, the simple explanation is EGFR mutant lung cancer doesn't have that many neoantigens because it's not a very complex tumor. But then over time, theoretically, it gets more complex, so there should be more neoantigens. But really, you know, neoantigens, not all neoantigens are the same. And so I think that if we can figure out what is it that can make that cancer more identifiable to immune system, we'll have ways to move forward. But I don't think we've figured that out very well yet. So.
Great. We have one from Katie Politti, who you know as well.
Hi, Katie. Yeah.
I don't know if we can have Katie give it live, her question. I don't know how to do that, so I'll just ask it. She says, she's one of the other leaders of our SPORE program in EGFR resistance. Says, thank you for a great lecture, Heather. Great talk. I was wondering what you think we should be thinking about to address the heterogeneity of resistance mechanisms that can emerge in individual patients.
Great question, Katie. So I think that as much as the targeted story is a beautiful story, and to be able to say, we found the deletion 19 and we treated it with erlotinib, and then the T790M developed, and then we treated with osimertinib, that only gets us so far. And I don't think we're ever going to be able to really get completely around that, because as time goes on, there's more and more heterogeneity in the resistance pathways. So we have to be thinking about it. You know, the straightforward answer right now is chemotherapy, because that doesn't really care so much about what the resistance pathway was. But it gets back to Sarah's question that eventually we've got to figure out how to get the immune system to be able to recognize the cancer and all of its various iterations as it becomes more resistant, and be able to tackle it. I don't have an answer as to how we're going to do that, but to me, that's really the only way we're really going to get at it, because, or to get it early enough that it hasn't had time to develop all of the resistance, and that's where the earlier stage therapy is helpful. But even there, I think that I don't know that we're going to cure with that approach, because I think that it only takes a few cells that become resistant to then grow up again. And so I think we've all got a lot of years left of work that we need to get doing to be able to make the impacts we'd like to make.
Right, and certainly by working through the cooperative groups and the societies and collaborating, given that this is a worldwide disease, so important. I don't see too many more questions in the chat. We're just about the end of the hour. I see Nancy Muring joined, and I just want to acknowledge her, John's wife. And I'm sorry we can't talk in person, Nancy, but you know, next year hopefully we'll see you in the front row, and we can, you know, we'll zoom Heather in for a picture. But Charlie, any final thoughts before we end?
No, Heather, was a fantastic talk. I mean, it really outlines what's so exciting in lung cancer, both with respect to targeted therapies and hopefully integrating IO with these things over time. So thank you. It's really powerful work.
Right, and thanks for taking the time. Thanks to everyone who joined. We had, you know, a very large crowd today, both because of you, Heather, and because of John. And we remember him fondly, and in his memory, we'll continue to take good care of our patients, and which was always his #1 goal, with the most innovative therapies, which is exactly what both our cancer centers are trying to do. So thank you, everyone, and see you soon.
Great. Thank you.